Okay. So good morning, everyone. Good evening, everyone. Also to
Evening.
India. So we're back again with more interesting lectures and seminars for today. So before that, I would like to introduce and welcome everyone in the Global Interdisciplinary Summit, which is all combined with Global Outreach Medical and Health Association. So I am Dr. Gagandeep Kaur, a team member of GOMA. GOMA is basically a global organization representing the medical and health profession. It promotes and provides accreditation, certification, education, training, and other resources for organization, professionals, and students. The Global Outreach Medical and Health Association has firmly established a leadership role in medical and health sector. So before moving on to the session, I would give some key points for the participants, basically for the certification purposes. So those who wish to get their participation certificate for the session must have a GOMA membership. And if those who are not carrying the GOMA membership, kindly register on www.gomha.org. And in between the session, we'll be sharing a link of a form. So everyone has to fill the form. Along with that, you need to have a seminar screenshot, which will be acting as a proof of the participation. And the submission of the form will lead to the certification that will be directly mailed to everyone. So with this, I would welcome to the speaker of today, Dr. Gurien.
Hello.
So I would, in speaking about him, moving on to his introduction, Doctors graduated in dentistry in the Faculty of Dentistry, Triana University in 2003. From 2003 and 2006, specialized in oral surgery and implantology with DDS. From 2007, pedagogy and lecturer in oral surgery, OMF surgeries, oral anesthetics, and implantology in the dentistry department, Faculty of Medicine Sciences of the Albion University. From 2009 to 15, Chief of OMF Surgery Cathedra in the Dentistry Department, Faculty of Medical Sciences in the Albanian University. So he's the inventor of the sticky tooth grafting material, co-inventor of the Gurien Demiraqi approach, a PAOO enhancement technique with hard and soft tissue grafting protocols. Member of European Association of Osseointegration, World Dental Federation, South Europe, North Africa, Middle East Society of Implantology and Modern Dentistry, Balkan Stomatological Society, etc. So with this beautiful introduction, I welcome you, sir, and the stage is all yours.
Thank you. Glad to be with you. I'd like to start with my presentation now.
So kindly share the screen.
Have you?
So kindly share the screen with us.
Yeah, I'm doing it now.
You may go ahead.
Okay. So, periodontally accelerated osteogenic orthodontics combined with blood concentrated growth factors and or sticky tooth or sticky bone. This is actually our approach to orthodontics. Enhancement to treat cases where there is no space, the alveolar process is too narrow, and the orthodontic tools are unable to be used because of that, because there is no bone and also no soft tissues most of the time. So why don't we do it all at the same time? Orthodontic treatment and gingival area coverage, and perhaps even better, to try to add some bone to it. Using this procedure of corticotomy combined with blood concentrated growth factors and more, as shown, this is our approach to corticotomy. Now, corticotomy for the 21st century in seminars of orthodontics is the aim to treatise and also use critical rationalism and analytical commentary in the chronicle of historical techniques which should be brought in the 21st century, adding the stem cells therapy, orthodontic tissue engineering, etc. And starting with some introduction of corticotomy, the first one to be speaking about it is Brian in 1892. And then later on, Cunningham, 1 year later, presented the possibility of immediate correction for irregular placed teeth. Later on, next century, it was the mid of next century where Heinrich Kohl in 1959 introduced his technique associated with orthodontic treatment to accelerate dental movement. Then later on, it was Chunk in 75 till 78, trying his idea of fast orthodontics, as you can see, trying to segmentate and then move in orthodontic manner. Later, Gennerson in 1978 tried to modify Kohl's technique by replacing the supraapical osteotomy with the supraapical corticotomy. What's the difference? The difference is that when you do an osteotomy, you have to go through the bone, and doing a corticotomy, you just have to go through the cortex. So the medulla remains intact, and you can do no damage, meaning to the teeth, which are vital to their connection with the rest of the jaw. But however, the movement can be very fast. Coming in this century, Wilco brothers were the ones to start with this kind of revolution with their accelerated osteogenic orthodontics, known better as Wilcodontics later on, which they very soon modified in periodontally accelerated osteogenic orthodontics, which is then the name that we are also using, which is also the name that is best known. They tried to also explain what's going on. So how does this happen? So why does the tooth move faster if we do this corticotomy? Jermik modified also later on the technique, and he published his article in 2006 in a monocortical technique, so just the vestibular side. And as you can see here, just small cuttings are performed and it will work. Next year, so 2007, Vercelotti and Podesta tried another vestibular approach for corticotomy, as you can see, with an epsilon shape with the electrical end-piece, and they called it the monocortical technique for dental dislocation and periodontal ligament distraction. Piezocism is the technique from DeBart in 2009, which introduced piezosurgery to the concept of corticotomy, with just doing these small cuts, as you can see in the picture, in the vestibular area, and just with that trying to move the tooth, which was actually moved much faster than in normal orthodontics. Oliveira tried some, let us say, partial corticotomies also in 2010 and published one of them in the intrusion of molars. And he reported that he tried to intrude 4 millimeter in one patient in 2.5 months, which is really good, and in another patient around that amount of millimeters, but a little more, just in 4 months, which is also good. The technique can be used in adults and also in young patients. The new procedure, or let us say the fancy procedure to do, is the endoscopic assisted tunnel technique by Hernandez and Guerrero in 2012, which just by tunneling vestibularly in the middle, or also 2 lateral incisions in the mucosa, and afterwards going with piezo surgery and also viewing it endoscopically, try to perform corticotomy, which is actually the less invasive possible technique, but difficult to perform, and also not perform, you can't perform this technique in all the cases. Our approach, we started it in 2014, and actually our idea was not to try to do it faster. So the other guys, they are trying to do it faster than normal orthodontics. We were trying to solve cases in which we had thin biotype of gingiva and leak of bone, which was our main problem. So in cases where you can't use traditional orthodontics, we started with our protocol, which contains a clinical examination, and a must is a 3D CBCT before the treatment. Afterwards, you need some blood analysis normally, and since we perform most of the cases in sedation, anesthesiologist evaluation is needed. We perform the corticotomy with BCGF, blood concentrated growth factors, sticky bone or sticky tooth accordingly. Then you can later go on with normal orthodontics. You can have also orthognathic surgery if needed in some cases. And at the end of the treatment, you also have a 3D CBCT to check your result, and also recalls yearly to see how is it going. So you have recession and so on. About BCGF, it's a technique that started in 2006. PRF was the first to describe platelet-rich fibrin. Dr. Garg spoke yesterday a lot, and he is the co-inventor with Dr. Robert Marks. And they put it in literature in 1998. The blood concentrated growth factor is strictly autologous fibrin matrix containing large quantity of platelet and low-side cytokines, with including the circulating growth factors. There are other types of PRF, PRP, LPRP, which can be used, and this all has been unified lately by Dr. Garg himself with the name autologous blood concentrates, ABC. So since the time is not so much, I'm going to skip much of the theory about that and go on to our approach. We used corticotomy associated with blood concentrated growth factor in orthodontic patients, as I said, with thin biotype and insufficient cortical bone coverage. CBCT at the beginning to check what's going on after you see it clinically, and then afterwards I require a minimum of blood analysis, which accordingly can be changed depending on age of the patient, depending on his situation and anamnesis. And then the surgical procedure, since it is a little long as procedure, is mostly performed under sedation. And we go to the buccal aspect of both jaws most of the time, but even in one jaw if it's needed only there. So the possibilities that we've seen are using corticotomy combined with autogenous thrombocytes and over it pressed white buffy coat, as I will explain, which is fibrin pressed in it. Sticky bone, also with the buffy coat pressed in it, or sticky tooth. The bonding of the brackets was realized before surgery, and the orthodontic activation starts immediately and is then continued with routine activations, which are made every 2 weeks. So this is our centrifuge. Others can be used. And this is what you get in the blood tubes: the serum, the white buffy coat with the growth factor and the CD34 cells under it, and then the red buffy coat, and then the metal ions in the end of it. To make it a little more specific, what we actually mostly need are this one. So the plasma, the activated fibrinogen, and then also the platelets with growth factors and stem cells in it. These are the programs you can program in the centrifuge, which are different from different centrifuges, but as I said, other centrifuges should work well in this technique. Then you've got collection kit with the gauge, butterfly gauge, and then the flasks. So this is our fibrin buffy coat. Actually, to aid our ideas, others have been tried to use it in orthodontics. There was a study, very nice, in dogs in 2017, which shows you the effect of platelet-rich plasma on the orthodontic tooth movement in dogs, which, as you can see, resulted in faster movement on the experimental than on the control side, which is also something that aids corticotomy itself. This is a sphero kit where we use to condense to press our fibrin clots, which is in titanium. And these are the clots, and you press it, and then you have here the pressed one. Another possibility, when you have lack of bone, is to make it sticky bone. And let us say you don't have enough bone, where to get it? Autologous is, of course, the best. And you can do sticky bone, or you have some teeth, which lots of times when you do orthodontics, you have some first premolars, third molars, and so on. You can try to use them, do them sticky tooth with our method. So don't discard your teeth. You can use them, and it's autologous graft. It's been used for some years now, and you need to use it, in my opinion, and I will show you why. The protocol is simple. Now it's about 8-minute protocol. You can clean it, dry it, and then graft it in about 10 minutes. You're ready. You're done. And let me show you how you do it sticky. So this is in real time, a procedure of sticky tooth doing. You add the fibrin, which is not clotted yet, and you press the before taken fibrin clots in it. Or at least this is how we do it. You can mix it together or even leave it. The result will be, let us say, not so different. It will clot in about 1 minute, as you will see in real time. So this is your grafting material. So this is it. This is a quantity that you can use. Actually, you can use it in one patient, in both jaws. So Autologous is, of course, the golden standard. It's bioactive and so on. And the tooth, with its hard nature, reduces vertical compaction and also maintains the graft volume in time, which is proved because we've got cases of 3, 4, 5 years, no resorption. It will be substituted slowly with bone. And this is our instrumentarium. We started doing it with motors and diamanted discs only for about 6 months to 1 year, and then afterwards we passed it to corticotomy, to piezo. And this is actually one of our, let us say, initial cases. It's about 5 years or 6 years now. And you start performing the cuttings in the vestibular region in both jaws, apically and laterally of the teeth. You have to go till under the cortical bone, and then you stop there. It's a feeling, actually, it's not that you have some, let us say, measurements. You will have some height from the CBCT, but then it's a normal surgical field. So I wouldn't, let us say, recommend someone to start doing it without having a course, without knowing what he is doing. But actually, some guys that has been using piezo surgery, that I believe it's easy to perform. So you go on cutting, and then also in the apical area. There are theories that even the cutting laterally is enough, but why risk it? Since you are there, actually, you can do it. So this is in real time what you can do. The instrumentation of piezo surgery is getting more and more complex, and there are more and more instruments to use, and they are becoming more and more powerful each day. Then, after you perform the corticotomy, another point of interest is the extension of soft tissues afterwards to be a recipient of the graft, or even just to change their position in way to enhance the gingiva. And we have been using the soft brushing kit for some time, and I will actually recommend it to you. It's good, works well, it works fast, and you can do a big amount of extension in very little time. Then the procedure, then after cutting, you have to place the graft. This is sticky tooth in this case, which, as you can see, the consistency is very good and very stable, and this assures you that it will stay where you put it. So you place it over the corticotomy site, you compact it over it, and then afterwards you place the membranes over it, and then you suture. So these are, let us say, the main points of interest in doing a corticotomy. Well, passing to some cases, and I'm introducing to you Modigliani, which is a famous Italian painter, because I've used some of his paintings. And I have a citation from Dr. Baruti, which wanted me to share with you. In letters in his sabbatic in Capri in 2001, he says, "Hold sacred all which can exalt and excite your intelligence, and seek to provoke and to perpetuate the stimuli, because they can push the intelligence to its maximum creative power." So let's pass to some cases then. The first case we did actually was to test the method. I wasn't, let us say, so sure about it. Dr. Baruti insisted, and she convinced me to try to do this procedure. And then later on, then we started doing it more and more, and we have lots of cases now to show to you. And this is just one small part of what we are doing. Female, 15 years old, missing the second premolars, 1525 in the maxilla, and they were replaced by the existing deciduous tooth 55 and 65, which were now moving, and they were leaving the mouth without the root. And there was a canine, actually, the delacerated 23, which was the one that made me start it. So we performed partial corticotomy with BCGF coverage only on this tooth, and the rest of the mouth was treated conventionally to try to test also the speed differences that are, let us say, said to be. So as you can see, this is the canine. This is the direction, which is actually very bad. And this hook over here was the one that made the Dr. Baruti, let us say, insist with me to start doing corticotomy. Because this one, she said, there's no way I can put it out in one piece without great resorption. Also, as you can see, vestibularly, there is not much bone, and also the other teeth to create anchorage were also at risk after we tried to let us say attract this one. This one, as you can see, is rootless. This one also, so they were removed. Actually, if I had at the time the grafting grinder from Cometa Bio, I would have gladly used it, so going back in time. But at the time, I didn't have it. I believe even Cometa Bio didn't have it at the time. It's 2014. So this is the mouth, as you can see. And these two teeth, which left so easily, brackets were placed. And then this is the corticotomy performed. Sorry for the pictures, it's old technology for now. And we placed a hook to try a chain to try to extract it. And then also the other tooth was to move. So the premolar, first premolar, 24, was to move backwards in order to leave place for the 23 to come out. And we did corticotomy here and here, and then covered it with a couple of membranes. And in 3 months, this is what we saw. The tooth started to come out, and this tooth moved very rapidly behind, leaving place for this one. And at the end of the treatment, we had, this is during also. At the end of the treatment, as you can see, we have this tooth in place, and then the rest of them aligned. And this happened simultaneously, believe it or not. So this is the end of the case, missing two premolars. The 14 and 24 were moved backwards. And as you can see, this is the finished case with the patient happy. Another case Later on, with only BCGF coverage, class 1 malocclusion, insufficient cortical bone coverage in both jaws, and very thin biotype. But the age was young. Treatment was to extract tooth 41 in the crowding in the lower arch and corticotomy with BCGF membrane coverage. The total treatment times were 3 months. This is the initial of the case. Intraoral view, as you can see, crowding. We have to extract 41 to make place because it was no space at all. And then this is the incisal look. Cutting in the CBCT. 3D construction. Corticotomy performed. Both jaws. Extraction here, as you can see. And BCGF coverage overall. Before doing that, I always use the serum to clean, and it has good antibiotic properties. This is the edema, because afterwards it's thought it's big surgery. It should have been very traumatic, but as you can see, the edema is minimal. And this has happened plus in all the cases. So the patient has not got a very big pain, let us say. Some little painkillers are given, some ibuprofen, some paracetamol, nothing fancy, let us say. And the patient has not got a big problem. The swelling, as you can see, is not so much. So it's a procedure that, even though it looks traumatic, it's not. It's a little long, but not as traumatic as one would assume. This is the bone regeneration in 1 month after the POW and the Panorex. You can see it, what's going on. And this is after 6 weeks. This is at the end of the treatment in 3 months. Check this out before and after, and the gingival improvements. Thickness, color, vascularization, always much better than before. Another view. This is then pictures taken 1 year after the treatment. Nothing has changed. Even later on, we have seen her a couple of years ago, and also all was stable, nothing was moving. And these are then the CBCT cuts after the procedure, as you can see. And comparison of before and after. And this is then the CBCT at 1 year, where you can see nothing has moved. The case with BCGF coverage. This one was a little older, 21 years old. Skeletal class 2 malocclusion, insufficient cortical bone coverage, and the teeth and in both jaws. Unilateral crossbite at the left side. Treatment, corticotomy, as I told you, and I also did extract 3 wisdom teeth, but no smart denting grinder at the time, so I didn't use these teeth. Treatment time, 8 months. This is the reconstruction prior to the surgery. And these are the intraoral views, as you can see. The correlation of the teeth. Corticotomy, both jaws. In the lower, actually, just in the frontals area. Extraction of the 3 molars, covering with BCGF. Then this is the maximum edema in 3 days. As you can see, nothing fancy. During the treatment, and the treatment ended in 8 months. This is at the end of the treatment. The CBCT afterwards. Comparison of before and after. As you can see, the teeth are moving and no bone exposure was seen after the treatment. Another set of cuttings. This is the gingival improvements you can see overall. Another view. Another case, BCGF, a female, 15 years old, has 3 malocclusion, very thin gingival biotype and insufficient cortical bone coverage in both jaws. Crossbite at the anterior region, asymmetry of the mentum. The treatment was PAO with BCGF coverage, and the treatment time was also 8 months. This is then the reconstruction of the 3D, and this is then the crossbite anteriorly. As you can see, the roots are vestibularly outside the bone, risky for an orthodontic to treat. This is the internal view. Brackets in place, BCGF. I believe it was about 80 or 120 ml used in this case. The cuttings, covering in both jaws. Maximum edema, 72 hours. Orthodontic treatment starting immediately after with the sutures in the mouth. As you can see, nothing moves them. So I also use most of the time the brackets to anchor my sutures, extra help, which is also a good help. And then the movement starts immediately and every 2 weeks. This is the situation after 8 months. Patient's hygiene could have been better, but however, the results were this. This is the before and after comparison. The CBCT at the end. Cuttings. And as you can see, there are lots of improvement also in the gingiva. Another case, 25 years old, class 3 malocclusion with maxillary hypoplasia, missing of 22 and 13 is retained, very thin gingiva and insufficient bone cover. 5 months later, after our treatment, surgery early was performed in the maxilla. We treated mandibula in this case. This is the initial situation. And check out the distal cuttings, triangular, to try to upright the molars. Actually, not to try, we succeeded in it, and we have succeeded in lots of cases. This will facilitate movement, and this will make the upright much easier than in other normal situations. We have used TADs later on also to improve even further. This is the covering with membranes, Theramus used. And this is the treatment starting in the lower jaw, CBCT, pre-surgical orthodontics. And this is the surgery early with Lefort 1. After surgery, orthodontics. And this is the finished case. So this is the before and after. And the improvements, as you can see, are visible. Another case, this one is with sticky bone. 13 years old male, class 2, division 1 malocclusion, root exposure in the frontal area. Treatment was done with BCGF and sticky bone. RPE and lip bumper was also used before. And 14 and 34 and 24 was extracted in order to facilitate the orthodontical treatment, but I couldn't use it. It was about 4 or 5 years ago, and it has been treated in 8 months. So this is the initial situation. As you can see, there is visibly no bone in the frontal region. Measurements, the cephalometrics, and this is the 3D CBCT cuts. As you can see, no brackets were placed in the first premolars as they have to be extracted. So corticotomy performed. You can see also these cuttings here and this teeth here missing. And this is sticky bone plus the membranes to be finished. Maximal edema, starting with orthodontic treatment, as I said, every 2 weeks. And then this is after the orthodontic treatment. This is the result before removing the brackets, so at the end of the treatment. This is the intraoral view, the before and after, where you can see the improvements. And this is the cephalometry at the end. Another case with sticky bone, female, 23 years old, very thin gingiva, supernumerate in the 4 quadrants with also anterior crowding. Both mandibular cuspids has got 2 roots, as you will see a little later on. We performed corticotomy with BCGF and sticky bone, and we extracted simultaneously for third molars, so the last third molars, and 45. For 8.5 months took it to reach the result. This is the initial situation, and here you can see 45 here to be extracted, and the 4 wisdom teeth also has been extracted. This one was put out. As you can see, the roots, they're outside the bone, so little can be done without corticotomy. Most of the orthodontists wouldn't treat this case. And these are the 2-rooted premolars, 43 3-rooted canines, two rooted canines, 33 and 43 in the lower jaw. Corticotomy was performed. Here a chain to put out the tooth 44. Sticky bone and BCGF coverage over it. Upper jaw. After directly starting the orthodontic treatment. This is about at the middle of it, after 4 or 5 months. This is the end of the treatment, where you can see improvements also in hard and soft tissue. Another case in vestibular boneless tooth. Patient is a colleague, 47 years old, female, but with hypothyroidism and iron deficiency, anemia. She took blood every 2 or 3 months, also treated with iron all of the time. Vitamin D levels very low, and cortical bone was missing, as you will see in the pictures later on. Thin biotype, anterior bimaxillary crowding, skeletally class 1, dentally class 1, left side class 2, class 1 right side, class 2 left side. Self-ligated rough 22 was used in this case. The patient is a doctor, she would have to work, so we did the best we could. Bone grafting with sticky bone and membrane coverage. This is how it was at the beginning. This is the CBCT before the treatment. The cuttings, where you can see there is almost no bone vestibularly. Membranes and sticky bone. Corticotomy. Here you can see the roots be seen directly after performing the incisions and the flap rising. Sticky bone and membranes over it, and starting with orthodontic treatment. Edema in this case was a little, let us say, much more than in the other cases, but with the hypothyroidism and the rest of it, with anemia, is this something that has to be expected? So this is the case when we had the biggest edema in the mole. This is then the finished result. CBCT after, where you can see the bone coverage overall. There is new bone. Before and after. And this is then the 3D of before and after, where you can see the bone improvements and also some soft tissues. Soft tissues have been seen. And this is it. Another case, this one is with sticky tooth. The 9th case, I have one more. I don't know with the time how we are, but I'd like to share these ones with you. 16 years old, female, class 2, division 1 malocclusion, high angle, bilateral crossbite, very thin gingiva, anterior open bite, V-shaped maxilla, mouth breather, lots of stuff. Frontal tooth densification with vestibular root exposure bimaxillarly in the frontal area. Treated before with RPE, McNamara type, to create a little expansion in the maxilla, and then we extracted 14 and 24. The premolars had 3 roots, which would have made them almost impossible to move, other than the crowding in the anterior area, but this was a good way to use them for grafting. This is the pre of the case, as you can see, and here are the 3 roots of the upper premolars. So this is before the expansion, and this is then after the expansion with RPE, before the starting of corticotomy. We extracted the teeth, which, as you can see, are really pretty, and they made a pretty good grafting material, which, as you can see, was then later used to fill the defect. So incision, corticotomy, piezo surgery, as always. Bone covering, sticky tooth, BCGF membranes overall, same in the lower jaw. And this is starting the treatment. This is the maximum edema that we had in this patient. After all that big flaps and everything, you should expect something very bad, but this is what you have. And this is then at the end of the treatment. This is what you have at the end. After around 8 or 9 months. As you can see, the coverage with bone, so the new bone, compare it with before. And these are the pre and post treatment, anteroposterior and cephalometric, and this is the final result. Another case, BCGF with sticky tooth, 19 years old, class 2 division 1 malocclusion, overjet of 10 mm, overbite 5 mm, short face, gingival smile with labial incompetence, frontal tooth densification with vestibular root exposure bimaxillarly in the frontal area. She refused orthodontic surgery, so we did the second best possible treatment, which was to extract 14, the radix of 26 and 41, and then we did corticotomy with grafting with sticky tooth and BCGF membrane coverage. We achieved bimaxillarly dental decompensation, superior maxillary repositioning to correct the gingival smile. Treatment time 8.5 months. This is the pre-treatment look. This is the intraoral view, CBCT cuts, where you can see lack of bone everywhere. This is before starting the treatment. These are the teeth that we extracted. So the roots and the 2 teeth, the roots of the first molar, BCGF in large quantity. I believe it was about 160 milliliters. In this case, corticotomy, sticky tooth, same drill in the lower jaw. Starting with orthodontic treatment, situation after just 4 months. CBCT We took it 4 months to check how it was going on. It was a difficult case. Situation after 6 months of treatment. And this is then the CBCT at the end of the treatment at 8.5 months. This is then the final result. The before and after, which you can visibly see the difference. And also you can see the improvements in hard and soft tissue. So to conclude, corticotomy combined with BCGF and more, sticky tooth is my best possible. If we don't have a little bone from the patient, I try to scrap some bone when I have the possibility. Gives us a short time of orthodontic treatments. As you have seen, these cases don't last more than 8-9 months. In normal, they should last a couple of years, 1.5 to 2 years, even 3. Painless and little edema in the post-operatory period. You can see clinical and radiological improvement overall. Of course, the mechanisms found can be summarized as bone metabolism induction through the corticotomy and also improved by the BCGF or similar, so similar as it, PRF, LPRP, PRP can be used, of course. The mechanisms are documented, and in all the cases that we had, which are a lot, we had improvements. But you have to understand that the protocol should be strict and should be followed in order to achieve the best result and to avoid the problems. And this starts from diagnosing the case till finalization. And also, so one surgery to enhance it all, things that you should have to improve later on by the periodontist, and also bone grafting, you can do it in one session. It makes it treatment much easier, and we have enhancements in soft and hard tissue that you can solve in just one surgery. So you don't need extra treatment after the orthodontics, and the results achieved is much faster than in any other conventional treatment. And they are more predictable. The case of sticky tooth, it's really easy to upsell this kind of situation if you compare it with time and other improvements. The patient will be glad, and he will also send to you other patients. What are the cons? This is Albanian photography of 1920, which gives you the idea of this tragical big surgery to be done in the mouth. Cons, patients not always accept surgery. There is actually a little bit more morbidity than in normal orthodontics, a little more pain. As I told you, conventional painkillers will do, nothing fancy, and a little edema, which, as you have seen, is not much. You've got the technical difficulties of this operation, more instrumentarium, and of course you need a surgeon, a good surgeon to do it, and also a good orthodontist to try to solve this case. It's a little expensive, but it's much cheaper than the other road. And in some cases, you can't even do the other road. So it is a solution. So this is my staff, orthodontist, anesthesiologist. Thank you for your attention. This is my email. You can find me also on Facebook if you have questions afterwards. Thank you.
Thank you so much, sir, for a beautiful oration, and along with that, you had beautiful cases to present to us. So with this, we'll move on to the questionnaire. We have certain questions from the participants. First, I'll move into Dr. Suraj. In cases of impacted canine, how PAOO and grafting will work?
Sorry, I couldn't get it much.
Yep.
In case of,
In cases of impacted canine, how PAOO and grafting will work?
yeah, well, actually, corticotomy will help. In cases of compacted canines, we have a couple of cases that were solved with the aid of corticotomy. It's actually much difficult than in normal cases, but it can be. So they will help you a lot, and they will make possible a treatment that normally you can't even do.
Okay. So we have the second question by Dr. Weber. What is the prognosis of post-operative stability of the occlusion when treatment is over? Does patient need long-term bonded retainers in cases like these?
Uh, Actually, we place, actually, I'm not the orthodontist, so I'm trying to answer for her. She places retainers, and normally we leave them for 10 years in all the cases of orthodontics we do. And we have follow-up of 5-6 years, and nothing has changed. Follow-up, I mean, not only objectively seeing, but even with CBCT. So no changes are in this period of time that I'm telling you.
Okay, sir.
So the result is very stable. You can count on it.
Definitely. Moving on to the next one, Dr. Ore. Best age bracket for corticotomy. Can you do the procedure without extraction and instead use other bone graft material?
Uh, if I understand correctly, the doctor needs to know the age.
Yeah, for
So
corticotomy.
corticotomy can be performed in every age. I've got a patient of 55 years old, and we did corticotomy and it worked great. I don't have this case placed, but the other doctor, as I showed you, was 47. So no problem of age in the cases. If you don't have to extract, if you have place, of course, you don't have to extract teeth. You can use autologous bone taken somewhere in the mentum or somewhere else, retromolar if you want. You can use bone grafting if you want to, but definitely I would use the PRF to cover it. It will improve your result and it will make it much faster.
Okay. So the next part of the question was, can you do the procedure without extraction and other uses
Yes,
bone graft material?
if there is place, yes, and it doesn't. So grafting has got nothing to do if you have or if you haven't if you don't do extraction. So extraction can be done. You don't even have to fill the alveolar with bone grafting. So it will facilitate movement in this area actually. Sometimes we use the bone clot, so the BCGF clot to fill the gap, but sometimes even we leave it free with it, and it will accelerate your orthodontic treatment.
Definitely. So moving on to the next question by Sushri. Which type of retainer you mostly used in these type of cases?
This is a
Retainers.
question that I shouldn't know to answer because I'm the surgeon in the case, but the
Okay.
orthodontist is definitely online, and we will see to answer to this question. So I'm not prepared in question. Let us say not much prepared in questions of
Okay.
orthodontic terminology.
Okay. And next question is by Dr. Suraj. Which burrs were used in cutting buccal bone?
Burrs, actually, we use piezo surgery. We don't actually use burrs, but when I did do it, I did it with discs, diamanted discs. They work well. They work also the same, but corticotomy is much safer. So with piezo surgery, it is much safer than using the burrs, the discs. So
Okay.
diamanted discs would be my go in this case.
Okay, sir. Next we have by Dr. Suraj again. What's the depth of cuts made over buccal bone? Ideal cut depth and any modification according to need?
So this is a tricky question. I can't answer it. I will answer it with a question. How do you know that you're in the apex when you do endo? if you don't have to have an X-ray at the moment you are doing endo, it's the feeling, and you have an apex locator, but it's an orthodontist, so an endodontist know where the apex is, and you also know where the cutting can go if you do it sometime. So you can feel the difference between the cortical bone and then the bone below. You can see a difference. So it's something that has to be done. It can't be explained in words. CBCT will help, as I told you, to see, but as you are performing corticotomy in each tooth, then it's something that you have to go with a feeling.
Definitely. Thank you, sir. And with this, I think we don't have much questions to be asked for. And I hope all the participants have their queries done. So thank you so much for your
Thank you.
beautiful oration and your knowledgeable session. So I think with this, we'll move on to the end of the session. So would you like to have some words added to this session end?
It was a real pleasure to be with you today. I hope it helps. But however, I would like to invite you to try to take a course or something in it. we do courses in Albania for it, also abroad. Yeah. So don't start doing it without the proper training. It's not as easy as it seems.
Definitely.
Thank you very much.
Thank you so much, sir. And to all the participants for C certificates and registrations, kindly log into www.gomha.org and stay tuned for more other interesting lectures in the series. Thank you. Thank you so much, sir.
Thanks.